Hello, everyone, and thank you for attending today's program on hereditary neuropathies, including amyloidosis and genetic testing. I'm excited for the upcoming hour to help educate our community about these important topics featuring first-class specialists. This program is generously being sponsored by Alnylam Pharmaceuticals, and on behalf of the Foundation for Peripheral Neuropathy, I want to thank Alnylam for their support and for making this program possible. My name is Lindsay Colbert, and I'm the Executive Director of the Foundation. Thank you again for entrusting us with your learning today. Before we get started, I wanted to let everyone know that we are recording this program, and a copy of the recording, along with the slides that will be shown, will be uploaded to the Foundation's website for future reference. We will also be holding a brief Q&A at the end of the program for those who are attending the session live. I ask that all questions be general in nature and on topic areas that our experts will be presenting on today. Unfortunately, we will not be able to answer any personalized medical questions. If you do have a question that you'd like to ask, please type it in the questions box located on the dashboard of the platform, and we will try our best to answer as many as we can during this hour. And now I'm pleased to introduce our expert panelists today. Dr. Amanda Peltier earned her medical degree from The Ohio State University and completed a neuromuscular fellowship at the University of Michigan. Board certified in neuromuscular medicine, Dr. Peltier specializes in neuromuscular and autonomic disorders with a focus on clinical trials and biomarker development for polyneuropathy. She is the Division Chief of Neuromuscular Disorders at Vanderbilt, Director of the ALS and MDA Multidisciplinary Centers, and a member of several specialized programs. Dr. Peltier is also President of the American Autonomic Society and a board member of the Foundation for Peripheral Neuropathy. Next is Shauna Feely. She specializes in genetic conditions affecting the nervous system. With over 2 decades of experience, she has helped build programs at institutions like Wayne State University, the University of Iowa Hospital, and Seattle Children's Hospital. Shauna's work includes clinical research and patient care, particularly in inherited neuropathies like Charcot-Marie-Tooth disease. She has contributed to gene discovery in neuromuscular disorders and served on medical advisory boards for patient advocacy groups. Shauna is dedicated to partnering with families to develop new treatments and cures for genetic nervous system disorders. And last but not least is Art Still, a former NFL player who spent 12 seasons with the Kansas City Chiefs and Buffalo Bills. A standout defensive end, Art was a 4-time Pro Bowl selection and the Chiefs MVP twice. In 2014, he was inducted into the National College Football Hall of Fame after an impressive career at the University of Kentucky, where he was a consensus first-team All-American and SEC Player of the Year. Diagnosed with hATTR amyloidosis, Art now works to raise awareness for this rare genetic disease affecting many in the African American community. And now I'm excited to pass the virtual mic over to you, Art, to start today's program and to share a little bit about your journey with amyloidosis. Thank you so much.
Thank you, Linda, and all for this opportunity of maybe getting more awareness out there too in reference to amyloidosis. And just, I'll just start my story off from the beginning. I was born and raised in Camden, New Jersey, went to the University of Kentucky, graduated in 1978, and as Linda brought out, played 10 years with the Kansas City Chiefs, was drafted, and then my last 2 years with Buffalo. But everything that has occurred in my life and all started off from birth. So as was stated earlier, I have the amyloidosis that affect you genetically and all. And throughout my career and all, been more so I've been involved in sports all my life and all. And what happened was, as you play the game and you pounding yourself, over 20 years, your joints, your back, your muscles and all, eventually you have problems with. So all through my career, even when I was playing ball, and even up until I was diagnosed, which was in 2023 of August, I thought it's all related to football, from bicep tendon to in reference to the neuropathy in my feet and other things that pertains to football that I took for granted that it was all part of the game and was part of growing up and getting old, turning into an old man, so to speak. But what I found out and what happened was when through the NFL, through the Players Association, they have a program, a wellness program. Every 5 years, we go visit down at Tulane. And it was just so happened this one time I was anti-medicine almost anti-doctor and all, because one of the reasons why I was anti all these things I'm talking about in reference to the health field is because my brother, who's 4 years younger than me, 14 years ago, he had a heart transplant and had all the exact same symptoms that I had. And that was the scary part. I'm looking at, from his experience of me experiencing the same thing. And till this day, he has the neuropathy and all too, where his stuff swells up. And I have, I'm coping with that right now. But it's, one of the nice things, one of the things as Linda brought out, that what we're trying to do is bring awareness out. And again, the neuropathy, the amyloidosis I have affect 1 out of 25 African Americans. And it's not about shade of color, it's just awareness of health issues within our own world and all, and within our own society and all. And I've been pretty fortunate to team up with another guy named Mike Lane, and we created the Amyloidosis Army, where we're trying to get information out in reference to this and how we can get not just awareness, but early detection and all. And again, it is a privilege and all for me and all. And I kind of look at it as, it's affecting a lot of folks. And when I found out with the carpal tunnel and all, I thought it was just strictly football, my feet cold. And then I was going with that thing, especially I call her my parole officer, my wife and all, Liz. I used to always tell her, cold hands, you hear cold hands are a warm heart. I guess I can't use that no more now. So, but it's been an experience for me, and the whole point is to help. And that's the whole point, is to get the information out there and get either a cure or be able to be able to cope with it and be able to acknowledge it and get the early detection. And as was stated, my background is more so in sports and raising kids, because I got 5 girls, 6 boys, and I got my 26th grandchild on the way. So again, with the genetic side of it, it takes it to another level for me. And one of the first things beside my personal family, but my other family, is the NFL and all. And so trying to get awareness out there, and doing my best to work along with the doctors, the pharmaceutical companies, with the medication out there, and also doing my part too of keeping myself in shape, what I eat and all too, to enhance this process. But again, I appreciate y'all for taking the time. If there's anything I can do for anybody, you can always reach me, my parole officer. No, just joking again. Uh, but feel free to reach out and all too. And Linda, and the foundation of, and I hate using that, peripheral neuropathy and all. I appreciate you guys giving me this opportunity to give my insight as a patient, as an advocate for this disease.
Yes, thank you so much, Art. We really appreciate you joining us today and helping to spread awareness about this disease. So thank you. I hope you can stay on and enjoy the rest of the presentation. And obviously, for anyone that has any questions for Art, we will be addressing those at the end of the program. Now I'm happy to pass the virtual mic over to Dr. Peltier, where she will begin her presentation.
All right. Well, thank you so much for that lead in. And thank you, Mr. Stills, because that's going to be a perfect lead in to our discussion. So I'm going to try to talk about hereditary neuropathies, hereditary amyloidosis, and I'll skim over a little bit the genetics, but obviously leave that for Shauna to cover. And obviously, if people, if I don't explain something well enough, please feel free to chime in. Let me, okay. For some reason, my slide's not advancing. So if you could hit next. There we go. So when we talk about the nervous system, it gets a little complicated. And so we traditionally have always talked about the central nervous system, which is the brain and the spinal cord. And then the peripheral nervous system is the nerves that come out of the spinal cord that are the motor nerves that go out to your muscles, or the sensory nerves that start in the fingertips or in the toes or anywhere else in your body and then end up going back up to your spinal cord and then transmit data back up to your brain. And then the third nervous part of the nervous system that we don't always think about is the autonomic system, which is those nerves that are basically coordinating the function of your heart rate, your respiratory rate, your blood pressure, your GI tract, etc. And the reason why those are important is that different neuropathies and different disorders affect different parts of the nervous system. And sometimes us trying to figure out what parts are affected helps us figure out what the likely genetic mutation is. And we can do that by a couple different ways. Part of it is what we see when we examine people in clinic, like whether or not is this a disease that affects the muscles or not? Is this a disease that affects the reflexes or not? Is this a disease that affects what we call large myelinated fibers that give you sensation for vibration and where you are in space? So like if you close your eyes, you know where you are, as opposed to the small nerves that don't have any insulation or myelin on them that are in the top layer of your skin, that are also part of the autonomic nervous system, that give you that stinging, burning, itching sensation when they're not working, and also kind of tell you what temperature things are and if you've if you've hurt yourself, the pain. And so inherited neuropathies are a fairly large, a decent portion of neuropathy. Now, obviously, the most common neuropathy worldwide is diabetes, but inherited neuropathies still count for about 7% of all neuropathy and a huge number of patients in the United States. And they can be motor neuropathies, motor and sensory neuropathies, sensory and autonomic neuropathies, which are pretty rare. In the original inherited neuropathies, were described by three neurologists, Jean Charcot, Marie, and Tooth. And so that's why the original inherited neuropathies are often referred to as CMT or Charcot-Marie-Tooth disease. And then hereditary amyloidosis was actually first described by Dr. Andrade in Portugal. And we thought that about 50,000 people worldwide have this disorder. It may be more, just because as we do more genetic testing, as it's become much more available and cheaper, we find that there's a lot more people out there who have inherited neuropathies than what we thought they did. So when we talk about, and I'm not going to go into great detail but when we talk about disorders, they can either be autosomal dominant, meaning that all you need is one bad copy of a gene. Remember, you have two copies for the most part of every gene, with the exception of genes that are on the X chromosome, because if you're a man, you only have one X chromosome. But otherwise, you generally have two copies of each gene. And so if it's a dominant mutation, it means that all you need is one bad gene to cause a disease. If it's a recessive mutation, it means that you need two bad genes to cause a disease. So unless your parents are related or just happen to have bad luck and both have the disease, it's very unlikely that your parents are going to have symptoms, but your siblings might. And then an X-linked case, where it's on the X chromosome, women may or may not have symptoms, or often will have symptoms but milder symptoms because only half of their cells are expressing the bad gene. And men will have much more severe symptoms because they don't have another X chromosome to counterbalance it. And then X-linked recessive genes are out there, but those are pretty rare. Now, if you look at all inherited neuropathies, the vast majority, or the most common, is what we call duplication, meaning that the gene itself gets duplicated in the PMP gene, which is what is the most common cause of what we call Charcot-Marie-Tooth 1 or 1A. And that accounts for about a little over half of all of the neuropathies all over the world. And then if you have a deletion in the PMP gene, you'll notice that that also has a big chunk. So that gene, for whatever reason, tends to get screwed up a lot. Um, and then there's other genes that, like MPZ or myelin protein 0, GJB1, and mitofusin 2 that cause a fair amount of mutations. Like MPZ is also a demyelinating disorder, also autosomal dominant. Mitofusin 2 is one of the most common axonal mutations that we see. So all those genes that, and then you see that there's tiny, tiny amounts of other genes. So other genes are much rarer. And when we think about inherited neuropathies, we traditionally mainly focus on genetic mutations that are mainly affecting the nervous system predominantly. Now, they can affect other organs, but predominantly affect the nervous system. And we divide those disorders, like I said, into disorders that affect the motor nerves, the sensory nerves, and the autonomic nerves. And so depending on which nerves are involved, will tell you which symptoms people will have. So if the motor nerves are involved, people will get weakness, they'll get atrophy of the muscles. In like classic Charcot-Marie-Tooth 1A, the PMP duplication, people will lose a lot of the muscle mass in their hands and in their legs, often starting with their feet. So they often have like high arches and hammer toes because of the way that the muscles are lost in time. And people can have really skinny calves because they lose those muscles in their calves, but they still have some muscles in their thighs and up here in their shoulders. Whereas the sensory fibers will kind of like help you know where you are in space, like I said. And then the autonomic fibers, when they're involved, can give you problems with sexual function, ability to use the bathroom, like, control your bladder, like either diarrhea or constipation or both, or difficulty with food moving slowly and feeling full very quickly, problem sweating, so people can have problems with temperature regulation. So all sorts of things that, and the reason why they're called autonomic is that they're typically on autopilot and you're not thinking about those things, they just happen. And so when neurologists first kind of figured out how to break up, like how to classify neuropathies, they did it based on nerve conduction tests, which if you guys have had one, you'll know that they're not the most fun thing in the world, but they are one of the oldest tests we have of nerves, where you actually apply a little bit of electricity to the nerves and you basically see how fast they conduct and the size of the response you get. So those big myelinated fibers will give us much bigger responses. It's very difficult. You can't basically find any small fiber response from an EMG test. So we had to get creative and learn how to do skin biopsies, where we actually take a little punch of skin and literally count the number of nerve fibers in the skin after we stain them, which was, but in the past, it was all basically just by examining the patient and figuring out what people were having. So like I said, CMT1, most common worldwide cause of inherited neuropathy, affects sensory and motor myelinated fibers. It's inherited as an autosomal dominant pattern. So you can have a new mutation. You might be the first person in your family who has it, but generally people will have a big family history where they have mom, grandfather, etc., and their kids, have a 50-50 chance of getting it. And people typically would have onset in their teens, occasionally when they're younger, like as children, but usually by the time people are in their mid-20s. And like I said, will often have weakness and sensory loss. And what you see on that lovely EMG test is that when you test the nerves conduct extremely slowly. So we see that the responses are super delayed and super slow. And a normal nerve conduction, so just to give you an idea, like when we stimulate, for example, at your wrist, down to your fingers, usually that's about, or from your elbow to your fingers, that impulse travels about 40 to 50 meters per second. or yards per second to give you an equivalent, which is pretty fast. Now, autonomic nerves and small unmyelinated nerves are much slower. They're about 1 to 2 meters per second. Still pretty fast, but not as fast. So, and that's why, you can react before you think about it. Now, Charcot-Marie-Tooth 2 was described as a axonal neuropathy, also inherited in a dominant pattern. And then and those patients generally have relatively normal speed, but the size of the responses are much smaller because the actual nerve itself is affected as opposed to the conduction, the myelin around it, which protects the nerve and allows it to conduct a lot faster. And then CMT4 disorders were autosomal recessive, and then CMTX disorders were inherited in an X-linked pattern. And you might be thinking, well, what happened to CMT3? Where did those patients, what happened to that category? Well, the problem was that before we had genetic testing, they used to say CMT3 were people who had onset when they're babies or when they were toddlers. And then what they found out was the same genes that cause CMT1 also cause CMT3. So then they just abandoned that classification. And then disorders that affect the small unmyelinated nerves are grouped in a group called hereditary sensory and autonomic neuropathies. Those are much, much rare. They typically will have a totally normal EMG because, like I said, the EMG only tests large fibers. And they are mostly autosomal recessive, meaning that unless you have two parents that carry a copy of the mutated gene, you're not going to have it. Now, hereditary amyloidosis is interesting because we often don't think of it as a hereditary neuropathy in the original Charcot-Marie-Tooth designation, but it is an inherited neuropathy, but it also affects many, many different organs and tissue types. So as opposed to the hereditary neuropathies, which mainly focus on the nervous system, this kind of affects a lot of different organs. And like I said, it was originally described in 1952, and we found that there are several other proteins that can cause amyloidosis. The most common is a mutation in the transthyretin mutation. All right, for some reason, if you could advance the next slide, because for some reason my forward arrow is not working. There it goes. And they all consist of this abnormal protein called amyloid, which is the Greek word for starch, basically, because it would look like this pink starchy gunk when you look at it under a microscope. And if you use a polarized light, it will look a little green. And what you're seeing is that these proteins, for some reason, will get misfolded, and then they come these loops that your body just has a hard time getting rid of, and it gets stuck in places that your body can't get rid of. And because it makes the tissue stiff and not move well and not function well, it can cause lots of problems. And so next slide. Now, in the transthyretin gene itself, there are over 140 different gene mutations. And some gene mutations are considered to be more nerve related or have much more aggressive nerve problems. And some gene mutations tend to have a lot of more heart problems. This, unfortunately, is also somewhat of a problem because it depended too on who patients saw and when they would come to the doctor. V122I, which is the most common mutation that we see in the United States, for the longest time was thought to be mainly cardiac and also affect like tendons and ligaments, but mainly because patients just had a slightly different type of neuropathy than the other patients that presented, like the early B30M patients who were described in the Portugal cohort. And so that neuropathy kind of flew under the radar, and cardiologists didn't recognize it. So while they thought only 30% of those patients had neuropathy, we found that that's not necessarily the case. Next slide, please. In transthyretin, the gene itself, carries or transports, that's where the trans comes from, thyroid hormone and retinol, which is vitamin A, which is where we get the name. And it's usually in a conformation where there's 4 proteins stuck together. And then when those proteins fall apart and then they become those fibrils, that's where we get problems. Now, some people, it can fall apart without a mutation, and we call those wild type patients. But in obviously patients who have a genetic mutation, it falls apart much faster and becomes more of an issue. And this is important because some of the treatments out there that help keep those proteins together, called stabilizers, are used for treatment. And then, of course, some of the treatments we use completely eliminate the abnormal protein altogether. So next slide. And the difference between amyloidosis and especially TTR compared to other genetic neuropathies is that it can go to so many places. Carpal tunnel is extremely common, partly because it loves to go to tendons and ligaments, and your poor median nerve that's in the middle of your wrist bones or carpal bones is stuck in between all those tendons going to your fingers, plus a ligament on top. And so that's why you get that double whammy of your median nerve really getting squished in carpal tunnel. And where it says AL here is because there are other more common type of amyloidosis that's not genetic at all. It's called light chain amyloidosis. And that is kind of a little bit more like a cancer if you think about it. And so as neurologists or as doctors, we're often trying to say, okay, is this inherited disease or is this type of cancer? But like Mr. Stills was talking about, bicep tendon ruptures are really common. Back and neck problems are super common. People can also have problems with the nerves, with the muscles. It can go to the muscle. People can also get sometimes deposits in their eyes, their kidneys. And then it can also really go to the gut and affects not only the gut wall, but also the nerves going to the gut. Next slide. And the tricky part about this disease is because it's affecting different things over time, slowly over time, it can take years for people to understand what's going on. And but usually carpal tunnel is one of the most common, earliest things that happen, followed by sometimes the spinal stenosis and some of the autonomic issues. And then people start developing the nerve issues and the heart issues. And those slowly accumulate over time until people actually show up at the doctor where they might have shortness of breath because they're in heart failure, or they might have enough weakness or numbness where they're having balance problems and can't walk. And they're often developing diarrhea that they can't control, etc. So, and so once those heart problems and more severe neuropathy happen, then untreated, those patients unfortunately can only live for maybe sometimes 5 to 7 years. So it is a very bad disease in that respect. Next slide. And a lot of times what we're trying to do is find those amyloid deposits. This is a picture of a heart biopsy in like different organs. One of the problems we have in neurology is that when you biopsy the nerve, it's only about 50% sensitive. So you have like basically coin costs to see if you're going to find it or not. And that's the other part of why this disease can be tricky to diagnose if you don't think about it and get genetic testing. Next slide. And these mutations happen all over the world, but interestingly in the US, the most common mutation is B122I, which, like I said, affects the heart and the nerves and all those other things, but used to be thought as primarily a heart-related type of amyloidosis. And unfortunately, that particular arose in West Africa and came over to the US via all the other people we brought over from West Africa that we will not mention how that happened. But obviously, that's pretty obvious if you're thinking about it. And then the other common mutations that we'll see in the US is T60A, which arose in the United Kingdom and Ireland as well. And so there's a lot of people in in the UK and the US with that particular type of mutation, as well as V30M, which arose not only in Portugal, but Germany, Sweden, Japan, other areas. Now, all over the world, the valine switch to methionine at the 30th position, the V30M, is the vast most common mutation. But in the US, V122I is the most common of all the mutations we see. Next slide. And the great thing for this particular mutation, as opposed to the other inherited neuropathies where we don't have good treatments for yet, in amyloid neuropathy, we have several treatments, which is great. So back in 2018, 2 different types of gene silencers came out. One was called patisiran, one was called inotersen. They both worked by basically keeping the protein from being made, the gene from being made into a protein. So they blocked your messenger RNA from getting made into a protein in your cells. And what they did was they tracked patients, and you'll see here, this is the transthyretin level. So you can see the people who are on the treatment, that protein level went very low. And so then they didn't have that continued buildup of bad protein. And so what you saw was that patients, when you look at their neuropathy impairment score or quality of life score, the people who didn't get the treatment kept getting worse and worse. So the higher the number, the worse it was. Whereas the people who did get the mutation actually, if anything, got a hair better. And same thing with their quality of life, which makes sense. If their neuropathy is not getting worse, then it's going to stay about the same or maybe get a hair better, as opposed to if it just keeps progressing on and on and on. And they saw very similar results to inotersen. Now, the problem with inotersen was that it also caused platelet issues, clotting issues, and it caused problems with the kidneys. So you had to get lab testing every week. So next slide. Next slide. And so the companies came out with new versions of those treatments, which are much better and safer and more convenient. So now there's a lot of injectable treatments that you can get either every 3 months, which is vutrisiran, or eplontersen, which is the newer version of inotersen, which is still once a month, but at least doesn't have to have all the lab testing. It doesn't have all the other issues. And then obviously people still get tafamidis, which was tried out in Europe for the neuropathy, but was bought by Pfizer and found to be helpful for the heart disease. And there's actually a new stabilizer that keeps a protein together that just came on the market this year. So more and more coming and more trials coming. So with that, before we run out of time, I will hand it over so that you can hear the next part of the talk.
Thank you so much, Dr. Peltier. We really appreciate your time. And again, any questions that are for you can be addressed at the end of the program. And now I'm happy to introduce and pass over the microphone over to Shauna. Thank you so much.
And thanks for that review of neuropathies and treatments. It's helpful going into this portion of the program. And doesn't look like am I able to control or not.
Sorry, Shauna, you should. Let me make sure that I can get it ready on our end. Passing it over.
Not seeing that, but
It looks like you should have control if you want to try to hover your mouse, click, and then start using the arrows. Otherwise, we'll do it on our end. Sorry about that, everyone.
yeah, it's not moving. So I guess I'll have to give direction on your end. So you can move past this slide and the next slide. Yep, next slide. Oh, sorry, back one. We're right in the middle of that. Sorry, next slide. there's a slide right before this. Okay. Um, Sorry, it's like moving past a slide from previous, but okay, we'll move on. So that side. As we heard, there are many, many, many different types of hereditary neuropathies, CMT being a lot of those, as well as different ones that cross over into other clinical features. And so when we talk about peripheral neuropathy, we heard a little bit about how that is defined. We often are looking at where the problem is stemming from, whether it's in the myelin or the axon. And so the myelin is the outside part of the peripheral nerve. Sometimes we kind of describe it as like the rubber part of an electrical wire. And then there is the inside part called the axon. And we heard a little bit from the earlier talk about how you use neurological exams and nerve conduction studies, looking at speeds and things like that, to define where the problem is coming from. And knowing that piece can allow us to guide families towards a specific diagnosis, because some genes can cause primarily problems of the myelin and some primarily cause problems of the axon. But the end result can be very similar with all of these different types of genetic causes, in that you can have distal muscle weakness and atrophy, sensory loss, gait changes, and all of these chronic changes can lead to a lot of fatigue and depression. There's over 100 different genetic causes for peripheral neuropathy, or even more than that, depending on how you define it. So we often think of conditions or medical conditions in silos, where we're not, you have one distinctive diagnosis. But in fact, especially in like the neurological disease space, there can be a lot of overlap in clinical symptoms, where people can have neuropathy, but also like coordination problems like ataxia or other symptoms. And so it can be difficult to diagnose, especially because these genes can also cause overlapping symptoms, and they don't always look like one distinctive thing. And then, as we were hearing, all of the clinical symptoms that you can have with like amyloidosis, especially like with TTR amyloidosis, you can have issues with heart, GI, changes in the brain, vision changes. And so that kind of has a splintering effect, where it depends on the particular individual and which symptom is really causing them the most day-to-day struggles. And so they may not all end up in a neurologist's office for a diagnosis, but in any one of these other specialties. So going into genetic testing is very complex and can feel overwhelming to a lot of families. And part of the reason is there is over 100 different genetic causes for these types of neuropathies. It's not really one disease that we're dealing with. And so symptoms can vary highly in terms of age of onset and the pattern of inheritance. Selecting the right genetic test can seem overwhelming and complicated, even to some providers that you might be working with locally. And so genetic counselors can help with this process. There's different types of genetic testing that we talk about with families. There are ways of doing single gene tests. So you're just checking a single gene to look at, for example, the genetic sequence and see if there are spelling errors in that genetic code that might be leading to clinical symptoms. There's also multi-gene panels where you're testing a group of genes. For example, there's hereditary peripheral neuropathy panels where you're testing a group of genes that all lead to the clinical presentation of peripheral neuropathy. We have larger, or what we call broad-based genetic testing technology now, such as exome sequencing. And exome sequencing is where we test all the active protein-producing genes a person has. So that's roughly around 20,000 genes. Those 20,000 genes are the part of the genome that produce proteins. So we consider them the active parts of the genome. But there are also genetic information that surround those areas. And so when we talk about exome sequencing, those 20,000 genes are just 1% of a person's entire genome. And in the space of things like neuropathy, I also talk about like non-genetic testing. For example, if you have a known genetic cause in a family and you can do a nerve conduction test or something to identify changes that would mean a diagnosis for a person, it's possible that people could get a genetic diagnosis just by doing a different type of test. Not everyone necessarily needs a genetic test in the family. So I like to think of it as kind of a spectrum from narrow to broad, where you may have like a known genetic cause in the family, and that's where you might want to approach a single gene test or even a known mutation test. Then we can think of these panels as growing larger and larger. Those are for people who may not know genetic causes in their family, but they're trying to decide which test might be appropriate for them. That's kind of in a narrowed way. And then we do these broad-based tests called exome or genome. So it's really talking about sort of the quantity or the number of genes and information that you're testing. There are many, many labs across the country that do testing for peripheral neuropathy, so it gets quite complicated. And not all genetic testing is the same. Labs differ in cost, what insurance is accepted for that coverage, and then also what genes are on their testing panel. So each lab has its own selection process. And that may mean that if you get tested at one lab, it's not, and didn't find an answer, you could get an answer had you tested over at a different laboratory. These panels change from year to year because labs select new genes to go on those panels. And genetic counselors really help to navigate this process. So, as I mentioned, not all genetic testing panels are the same. They vary in cost, the number of genes, and the specific genes that are included. One of the tools or instruments we use to identify differences is called Concert Genetics. It's available online, and this is where you can compare genetic testing panels. We can typically look at which labs are available for testing and what is included on those panels in terms of quantity of genes, things like that. If you went on and searched this would go on and on. There's quite a number of labs that provide peripheral neuropathy panels. What's not so as transparent as the cost and which types of insurances are covering these types of lab panels. The existence on a panel does not mean that gene has a definitive role in the disease. Remember that each laboratory has its own selection process of what they want on their panel or what they include. And so some may include things like genes that have maybe more limited connections to human disease. So we use this gene classification system or to check and see, does a gene have a definitive role or is it a moderate or limited role, meaning how much evidence do we have that that particular gene is responsible for causing certain symptoms. And if we don't have that strong definitive role, then we may only get things which we call variants of uncertain significance, which are changes that we do not know what they mean in terms of their role in human disease. And that can be very frustrating for families to do genetic testing and come up with some non-answers, for example. And the other problem we run into is the number of genes tested increase, so do the possibility of those variants of uncertain significance. So when we look at genetic testing, the goal is to have a positive test, meaning you found a change or a mutation in a gene that is known to cause a particular symptom, and that gives a diagnosis. A negative test means no mutation was found or no change that was found that we know is causing that phenotype. So it doesn't give that person answers, but it does not rule out that that could be that person's uh, diagnosis, or that they still could have a genetic cause for their symptoms, because we don't know all the genetic causes of peripheral neuropathy. And as I mentioned, there can be variants of uncertain significance. These are changes found in genes, and we do not know if they are disease causing. So it leaves you with more uncertainty. And just because something is rare and there does not mean it's disease causing. We all have these unique variants in our genome that are just part of normal human variation. So it's important to work with someone who can help you figure out if that change is benign or causing your symptoms. So I wanted to touch on what genetic counseling is as a genetic counselor, because sometimes people have not heard of this profession. We help people understand and adapt to the medical, psychological, and familial implications of genetic contributions to their disease. We help people we guide them through the testing process, facilitate the most effective approach to testing, and identify the most likely way to get a positive test result. And then we also help with reviewing the pros and cons of testing for patients to make a more informed decision. So, and the part of our role on the other side is when we get through genetic testing process, we help to interpret genetic testing information and inform patients and educate them and their families about what that means in a practical sense for them. So during a testing process, we'll take a family history, review the basics of genetic testing or genetic inheritance, go over information about the genetic condition, and then go through the genetic testing options. For example, which test, pros and cons, the ordering method, the plan and cost, and then interpretation and implications of results. So genetic testing is not a required step when seeing a genetic counselor. I know a lot of times people think they're the same thing, but I do have patients who come to see me and they decide that maybe at that time in their life, genetic testing is not right for them. So you're not required to get genetic testing if you see a genetic counselor. It's simply an access point to be able to find out more information and be able to decide if and when you want to move forward with testing. There are pros and cons to testing. Pros include tailoring prognosis and recommendations, having like anticipatory guidance on what to expect in terms of other symptoms that could be present from that genetic condition, access to clinical trials, treatments oftentimes may require a genetic diagnosis, having a definitive answer, which can bring relief of uncertainty and anxiety, and it also may allow you to have reproductive decisions or determine if other family members are at risk. Cons can be that testing may not be informative, as I mentioned. Sometimes we can't find an answer. The genetic testing may not be available because there is new testing that's coming down the pipeline, but it's still in research phases. There can be impacts on family dynamics that we wouldn't expect, and even psychological distress. For example, if a group of siblings all have the same genetic condition and one person tests negative, maybe that means that they have survival guilt or feel pain for the other family members that are going to go through these symptoms. It can also bring up issues like non-paternity or genetic discrimination concerns. And sometimes people have concerns about the overall cost of testing. But I always mention to people that this is, with new technology, this is really coming down. So it's important to ask these questions because they have significantly changed in cost since the 20 years I've been working in this population. And there's also maybe programs to help sponsor testing. So I know I went through that very quickly because I wanted to allow for time for questions, but I did want to mention a genetic testing checklist to help you, guide you through finding how to get a genetic test. So you want to identify a provider because these are typically tests that you need to be ordered by a medical provider and ask what testing is right for you. If your provider is unsure, you can also ask for a referral to a genetic counselor near you. And then in preparing for your genetic counseling visit, you want to know your symptoms along with the timeline, and then also know your family history as much as possible. Put a little turkey in there because genetic counselors say remind people that Thanksgiving is also Family History Awareness Day. So while you're sitting around the table, you can ask if other people are ever having similar symptoms as you. I know that's a fun conversation, but maybe better than others. So what do you do with your results? You want to make sure you understand your results and what they mean. You want to know the mutation that you might have and the implications of different clinical presentations from that mutation. You want to try to communicate this with other at-risk family members, and a genetic counselor can definitely help with that. And if the test is non-diagnostic, we recommend medically that people ask for a reanalysis of testing or potentially new testing every 2 to 5 years. So if you've had a negative test result, you want to go back to your doctor and encourage them to repeat testing or consider a referral to a genetic counselor at that point. These are some helpful websites. I'll point people towards NSGC, which is where you can find a genetic counselor near you. But there's also helpful websites there. And I'm going to stop at this point so we can bring on other individuals and answer your questions.
Thank you so much, Shauna. And as a friendly reminder to everyone, we are going to be able to share and upload this slide deck. So all of the resources that were provided that you were able to see today will be uploaded onto our website so everyone can stop feverishly writing those website pages down. Well, thank you again, everyone. This has been an amazing presentation. We do have a lot of questions, one for each of you, in fact, and depending on how much time we have left, maybe we can tackle a few others. So, Dr. Peltier, curious if you could answer, right? Lots of our neuropathy patients might not know if their neuropathy is inherited or not. And I'm wondering, and they're wondering, is that diagnosis really important because of how it might impact their treatment?
Well, so yes, because if you have an inherited neuropathy, it can be affected by other things, like obviously, behaviors like a lot of drinking, tobacco smoke, things like that are bad for your nerves just as well as they're bad for your heart. And so those aren't going to do anybody any good. But if you have an inherited neuropathy, that generally means that there's very specific treatments that we're looking at as far as genetic treatments. And so that's why it's important to get tested, because it used to be thought, and that was part of our understanding or lack of understanding about genes, was that if you didn't have neuropathy start when you were a kid, it couldn't be genetic. And we know that that's not true. And as genetic testing, as Ms. Feely mentioned, has gotten cheaper, has gotten easier for people to access, because it used to cost thousands of dollars. Remember, it cost like millions of dollars to sequence the entire human genome, and now we can do it in a few weeks. As that's gotten cheaper, we now have recognized way more genes. And that's also why Ms. Feely was talking about the fact that if you had a negative genetic test before or had a variant of uncertain significance before, it only takes a couple of years as people update all these databases to change whether or not that variant is now considered mutation or not. They're always adding new genes that we now discovered that are part of causing disease. And so we now know that a lot of people who have onset of neuropathy in midlife or older, I mean, I have patients who are getting diagnosed with hereditary TTR. I had a patient who I saw last week who got diagnosed at the age of 82. Now, granted, he had had symptoms for a lot longer than that, but, it can happen, it's one of those things where age is not as big of a question mark now. So it's better to get the test and know, I think. But you do have to think about what that test means. So
Yeah. Well, thank you so much. And this might segue nicely, Shauna, into another question, which is, someone said that they've already done their genetic testing. They were tested negative for the standard neuropathic genetic panels, but they still feel that there's a strong genetic component based on some other family members' kind of Thanksgiving Day family history chat. So, what would you suggest for folks to do? Do you recommend having multiple tests done every so often, a frequency? What advice would you give folks that did get some panels in the past and just still are trying to understand a little bit more?
So, and I would add to the previous question too that not everyone that we see with hereditary neuropathy, particularly with like things like TTR mutations, have a clear known family history, because these symptoms can splinter across a family, and someone may have more GI issues, someone may have more heart, and so it may not look like a clear pattern when you're just looking at these little glimpses,
Yeah.
or you could be the first person in your family because of a new genetic change. So while family history is part of the clues that we use, it's not, I would not rule out a genetic cause just because someone has no clear family history. And yes, definitely, if you've had previous testing like panels, you don't know exactly which lab you used, how many genes were tested. As I said, the number of genetic causes are growing and growing. And a provider and a genetic counselor can walk you through what may be the next steps. Certainly, if it's been over 2 years, we recommend you start continuing to ask these questions as new genes are identified all the time, and they may now, have treatments. We, as part of a program through the Inherited Neuropathy Consortium, we've identified new genes that went directly into clinical trials and potential treatment. So it's a very powerful space right now in terms of new gene identification. But in the end of the day, if you've come through testing and not had a diagnosis made, then you do want to continue to ask questions to your providers. And if you're thinking of something that's more broad-based, like exome sequencing or genome sequencing, some labs will then allow you, if you don't get a diagnosis from that type of testing, they'll allow you to do a free reanalysis after a year so that you can continue trying to investigate a genetic cause for your symptoms. And a genetic counselor or provider should be able to navigate you towards those labs that provide that opportunity, so that once you've done the more expensive test, you can continue to use that data over time.
Well, that's great. Thank you. And Art, question for you, right? As a former athlete, are there any specific exercises or therapies that you found helpful to kind of minimize some of the symptoms that you've encountered?
I was going to say, this has been an eye opener for me, very informative too, as far as because I was causing, even back in the day, it was all about sports. Now I'm not. I mean, this knowledge right here about neuropathy, how it affects your whole body, and then you was talking about the genetic side and all too. Um, and I was going to say, and just to clear up, you was talking about the genetic side. It wasn't until 2023, Dr. Ferdinand down in Tulane Medical Center, because my refusal to take medication, take all this stuff, because I do have AFib and all too. Um, he sat me down and asked me. He said, ask me about my family history, and that's when everything came to light and all, because as I stated before, I wasn't anti-doctor. If I had broken bone, I was going to see a doctor. But in reference to seeing what my brother went through, he had the neuropathy. They did surgery on his back. He had the stenosis. He done had surgeries, torn bicep, carpal tunnel, everything I done had. And so that put a bad taste in my mouth. But again, once I found out in 2023, I went back to him, and he immediately went to get tested and all, and found out he had it. I got another brother who's got a pacemaker in him. He needs a transplant. So it runs in the family. I got brothers and sisters that have all kinds of issues. And then on top of the one, my brother, my older brother, James Sparky, his son, Jemai, at 36 years old, he passed away, but he had sickle cell, and he found out that he had amyloidosis. So it was just one of those deals where, again, the early awareness, early detection is very important, no matter if you got the genetic side or whatever. But it's almost like you said, you got to take it upon yourself, be your own advocate as far as learning these things. Like I said, I failed today. I knew a little bit. When I first was given the symptoms and all, when they use the technical word, the medical word, instead of saying swelling, maybe tingling in your feet and all, it didn't make any sense because a lot of times, you see these words, these medical words for the common person, they look at, oh, I don't have that. But when you start describing the things, it takes it to a new level and all. And that's where it kind of put life in, perspective for me. And then my brother younger than me is married to my other parole officer, my wife and all. Um, he's already stated, he said he don't want to know. But see, in my mind, it's almost like that. He's got 3 kids, he's got grandkids. Same thing with me. As I stated before, I got 11 kids. I got my 26th grandchild on the way coming in September. So that's my responsibility. And that's what I always tell people. Maybe you might not want to know, but if you have other people on that line right there, family or cousins and aunts or whatever, uncles, whatever, and all, you need to spread the word out. And that's one of the things being part of this panel and all, of getting the word out. And, it doesn't matter if you have it or you don't have it. You got friends and family members, you got neighbors and all too. So once you make informed decisions or learn about things, that's where you pass it on. And in regards to eating and all, always when I was playing ball, you're always looking for an edge in sports. And it's the same thing. I said the biggest sports there is called life. So one of the edges is what you put in your body, because a lot of times, and I'll use, just like diabetes known for, I see there's a connection with neuropathy and all too. But and I see a lot of folks, and I got family members and all too, that have it, and they got to take either shot or either the pills and all. But yet and still, what they put in their body, sometimes people figure just, okay, I got the pharmaceutical over here, I can do everything over here, and exercise and all those things, takes it to, now you're working together as far as, for a positive outcome as far as in your medical field or health field and all too. And so I always encourage, like with me, like this morning, I'm in the sauna working out, even though, a lot of times, they say, hey, you don't want to push yourself too hard, but I find out what I eat. I do the fasting, intermittent fasting, and all those types of things, and gather knowledge and make informed decisions. That's what it's all about, making informed. And I'm very thankful to be part of this panel, but I'm also very thankful, for all the information you're providing here, because I'm gonna take it back and I'm gonna drill the family with it.
Well, thank you so much, Art, and thank you, everyone. Unfortunately, we ran out of time. There were so many amazing questions we weren't able to get to, and for that, I sincerely apologize. On the next screen, you'll see some information for how you can get in touch with us, so please feel free to follow up. Please also take the survey at the end of this program. It allows us to make sure that we're catering these types of educational resources appropriately for you. And thank you again to Alnylam for their support. Thank you to each of you for your support. If there's something that we can do to help, feel free to contact us. And the panelists online with me right now, thank you very much for your time and support. It really was an inspiring conversation. And I thank you all for your time. All right. Bye, everyone.
Thanks.